Good morning, good afternoon, and good evening, everyone, and welcome to Module 4 of our Neonatal Nursing course. And today we're going to talk about the cardiovascular system. So before we start, I would like just to go through some of the organizational topics. So please raise your hands. You can use raise your hand button to demonstrate, to let us know that you can hear us and you can see the screen properly. So please use raise your hands. Perfect. See your hands. So that's excellent. So my name is Margarita Singer. I'm the marketing manager for neonatal care at Dräger Middle East and Africa. And I'm also a certified trainer for neonatal care. And today we have again our guest speaker, Ms. Linda Pretorius, who is a developmental care consultant and a neonatal nurse from South Africa. Linda has graduated from the Natal Eddington's campus with a diploma in nursing, and then she's done her specialization in the management of preterm infants and neonatal care. She continued to work and run several NICUs and also pediatric ICUs, and worked in the UK before coming back to the South Africa. And now, of course, she is one of the key opinion leaders in neonatal care in South Africa, and we are extremely honored to have her here today with us. So in today's module, we're going to talk about the cardiovascular system of the neonates and the preterm neonates. And we're also going to address some of the challenges that are associated with prematurity in relation to the cardiovascular system. And as a part of hands-on demonstration, I'm going to talk about our Dräger Transport Incubator, GT500, with an incubator, TI500, and an integrated ventilator. So as a short recap, we're going to start with the case discussion that Linda has prepared for us today. And this case is based on some of the questions from the previous module on the respiratory care and also on the current module on the cardiovascular system. We are going to open this session for questions and answers after the case discussion for just 5 minutes, because we believe that this is quite important that the people are able to, or you are able to ask your questions with regards to the actual case. And then we're going to continue with the lecture. So again, in case if you have any questions, please type them into the question box. You can find the question box on your right-hand side in the GoToWebinar panel. It might be collapsed, so you need to use an orange arrow to open it, and there will be a question box. And we will be happy to address your questions. So now I would like to give the word to Linda, who is going to start with the case discussion.
Good morning to everybody online. Today we're going to start a little bit differently because I would like to bring together the respiratory system from the last 2 lectures and the cardiac system today. So I am actually going to present a case that has occurred recently and just talk you through it. So what we are going to discuss today is congenital diaphragmatic hernia, or CDH as it's known. And basically what this means is that you can see here that this baby only has a diaphragm up into about here, and then this that you can see in here is actually intestine within the chest cavity. And this happens prior to birth, and we will go through all of that as we go through this. But I just want you to understand, so 95% of CDH actually occurs on the left side of the baby, whereas So let's start there. This is a congenital defect that develops in the 8th week of gestation. Now, if you go back and we look a bit later, you will understand that the heart and the lungs develop at the same time. It occurs in about 1 in 2,200 live births. It should initially be diagnosed on ultrasound pre-delivery in the 2nd trimester. And what it is a malformation of the diaphragm, usually on the left side. So as I said, 95% of these babies, it occurs on the left side. We have the stomach and some of the small intestine up in this chest area here. Only 5% involve the liver on the right side. And the severity is determined by the liver position, so where the liver actually is in this presenting in the case, and also the lung to head ratio. So what this tells us is that the more inflated the lung is, the better the outcome. But if there is very little lung development, then we are heading for a problem. So the baby was born in May 2021. She was born at 35 weeks and 1 day, following 3 doses of antenatal steroids. Mom had been admitted various times in her pregnancy. She had turned down the neonatal, the fetal scan. Initially, the APGARs were good, but, and I have to mention this, there is evidence of a fairly vigorous resus in the beginning, and she rapidly developed RDS. She was intubated and ventilated. They did a chest x-ray, and what they found initially was intestines on the left side, and they decided to airlift her to a surgical unit 400 kilometers away. On week 1, surgery was done on day 2. So between being airlifted and receiving her surgery, she was ventilated. When they did the surgery, they found that the organs were smaller than was thought to be, that the heart was completely rotated. So the heart had rotated and was sitting on the right side. And they found part of the liver in the chest, and there was no diaphragm on the left side. This is very, very important because the prognosis for this baby is quite poor. Because you must remember that if the intestines have been here developing since the eighth week of pregnancy, there was no or very little lung development here. There was very little lung development here because the heart has rotated and prevented the entire lung field from developing here. The same had happened on this side. So she developed edema, which is quite common because very often the fluid resusces are a problem. She had an anemia, which was treated post-surgery. She was placed on nitric oxide and on oscillation ventilation. She was sedated and ventilated. Inotropes were started. And one of the main reasons for the inotropes was to actually improve the blood supply to the bit of lung tissue that there was, as well as supporting the kidneys, because I can tell you that there was an element of renal failure because of the edema, and she started TPN. On week 2, only in week 2 did she pass meconium. This is very, very significant. Breastfeeds were started, but not well tolerated, so she was fed nasogastrically. There was no buccal feeding done. She did have a small bowel perforation, which they then elected to keep her nil per os for another period of time, and she presents here with sepsis. This would be considered late onset sepsis. In week 3, she starts absorbing her feeds, but poorly. She is visited by mum. Mum lives 400 kilometers away and has to drive up and down. She was treated for another amount of sepsis. She was still edematous. She was weaning off ventilation. She started tolerating her needs better. She remained sedated, and she was never to this point handled by mum. In week 4, There was very limited visiting time due to the COVID outbreak in South Africa. The heart shows growth and improvement. There is still signs of sepsis, and antibiotics are changed again, and definite sepsis is diagnosed when the baby almost crashes on the ventilator, requires 100% oxygen, and now we can see the left lung on X-ray. So this tells us that the lung is growing. On week 5, she's now weaning again. Feeds have recommenced. She weighs 3 kilograms, still no physical handling by mum. Up until this stage, mom has been told not to touch her because she becomes unstable when they touch her. And she is responding. Week 7, week 6 was uneventful. In week 7, there's a decision made to start steroids to try and get her off the ventilator. Oh, there's a spelling error, sorry. Breast milk was stopped and neocate was started. They started weaning her sedation and still no cuddling or holding by mum. Mom reached out to the group to say that the breast milk has been stopped. She feels depressed about this and no solutions were offered. Mom now actively starts looking at Facebook groups, congenital diaphragmatic hernia groups, and self-help groups. She's asking a lot of questions. She's still not allowed to cuddle, fights to get bonding squares within the unit. They will not even allow her that. Week 8, mum decides that she is now taking charge. She wants to stimulate the baby on the ventilator. Mom decides to move to Durban temporarily to live nearer the baby, and mom has a COVID scare. Week 8, the babies are much less sedation. Mum's able to talk to the baby. She's now allowed to stroke and touch the baby, and mom is promised to hold the baby the next day. And then baby goes into severe septic shock. Parents are called to the hospital earlier, and she passes away that evening. What is the problem with diaphragmatic hernias? Well, firstly, we have to stabilize the hemodynamics. And as you can see, that is going to be very, very difficult because here we have very, very little lung tissue through which we can cause gaseous exchange. So watching the hemodynamics would be very, very important. The doctors would treat with ECMO or nitric oxide. In this instance, they chose nitric oxide. I think it was given for 2 weeks. She was on inotropic support to improve and to optimize the oxygenation happening via the lung. She was given TPN to grow. They tried to commence early feeding, and the positioning became very, very important with regards to this baby. But what was the actual problem? So from a medical point of view, I think we need to sit back and actually look at this very, very carefully. Firstly, the mother had a very difficult pregnancy. She was in and out of hospital. She was admitted a few times, and there was stress involved. This would mean that the baby would receive the cortisol from the mother via the placenta. Cortisol does, because once the baby was born, the baby became stressed herself and would have oversecreted cortisol. So let's look at what are the problems of cortisol. There's a decreased metabolism. There's a chance of depression. There's a chance of hypertension in older people. There's signs of chronic fatigue. There's sleep deprivation. There's tunnel vision. There's acid reflux disease. There's a hunger, there's pain, arthritis, and there's a decreased immunity, because actually cortisol is a cortisone. And where does cortisol work on? What does it work on? So it puts down in small doses, the cortisone will actively promote the breakdown of fat. In large doses, we often find that people gain weight. It affects the pancreas, so it affects the insulin release. It affects the muscle, decreases the amino acid intake of the muscle. And this leads to chronic fatigue and this arthritic pain. And it affects the liver. So there's a big use of glucose. We can see these babies and we can identify them by looking at their hemodynamics. Their heart rates go up. Their glucose is often on the higher level of normal. So they sit between 7 and 8 very often. And these babies are fatigued. They are often floppy babies because they just don't have the energy to work. Now, once a baby's in an intensive care unit and this ill and goes for surgery and ventilated, the secretion of cortisol happens all the time. And this is not going to be to the benefit of this baby. What is the counteracting hormone to cortisol is something called oxytocin. And what does oxytocin do when it works properly? Well, one of the things oxytocin does properly when it works properly is that it controls your emotion ability and your appetite. It creates good glucose hemostasis. There's much better food uptake. The kidneys work better. The gut has motility. The pancreas works better, so we have glucose control, and there's thermogenesis that occurs. Now, if we were to go back here, just back here from week 1, you will see that this baby is starting to show us signs of huge doses of cortisol. Meconium passed late. Problems kept nil per os. Week 3, starting to absorb feeds, still sedated, turning septic. Week 4, very limited visiting heart. The heart is showing, but septic again, baby crashes. Week 5, now weaning and absorbing. There is weight gain, but the baby still in the photographs appear edematous. Week 6, uneventful. Week 7, we now add steroids. So we've already got cortisol level and we now add steroids. We stop the breast milk and start neocate. Remember that breast milk at this stage would still be secreting growth hormone. And because of that, you will see the lung growth happening. Now we stop that by starting a formula feed. Mom starts getting worried. She's starting to reach out. She's still not touching this baby. So at no stage during this entire system did this mother hold this baby until she was passing away. And these are now starting to show up as problems. It is not fair for us to hold back, and that we can actually have given this mother an opportunity to hold this baby and actually have given this baby A, some pain relief, B, ensured that this baby knew that she was okay and she wasn't just lying somewhere in the abyss. The prognosis was poor from the start, and it's very, very important that the parental support is there, because long term what has happened is that this mummy has become severely depressed. And my entire reason for presenting this to you is that this baby should have been held by her mom somewhere in that time. Yes, she was ventilated, but there are guidelines, and I've put them here for you for moving the ventilated baby onto the mother for skin to skin. I've also put a very important podcast for you here from Canadian Premies. This podcast now looks at exactly what happened at the end of this baby's session in intensive care. So she became severely septic and she went into septic shock. And what happened is that affected her heart. It weakened her heart muscle, and the heart muscle no longer could have continued doing the work it needed to do. And that in itself is problematic. There's a new trend throughout Europe and America, and I see some of the hospitals in Asia are also doing it now, that when babies start getting severely ill very quickly, the doctors actually start doing sonars and looking at organ function, because what they've found is that very often the cardiac muscle's involved, and that the babies need more than just inotropic support, but that they need the cardiac muscle support, medication to make the cardiac muscle work. And so I would encourage you to please go ahead and look up Canadian Premies on Facebook and look at their hemodynamic talk that they do and how they use sonars now. There is also an article here for you to read. I've put down the guidelines for moving the skin-to-skin infant to the chest, and I've also given you a further publication to read on on congenital diaphragmatic hernia. But just for you to understand that once that baby, and I just want to go back here, once they do the surgery, there's a few things that we would have to take into consideration. It is very likely that this baby had a large ductus arteriosus. I am not sure if that was ligated during the surgery. That would affect the way the baby would respond on the ventilator. It is very important that we realize that there was multi-organ involvement here, and that the heart was small, and that is probably why the heart muscle gave in. And that due to the fact that she did receive some breast milk, we did see some lung tissue growth, but I don't think that it would have really made a difference to the outcome. However, part of the sepsis picture here is not being able to go to skin, not being able to colonize, and not being able to regulate from a developmental point of view, and this was stressing the baby. Marguerite, can we open for questions?
Yes, thank you so much, Linda, for presenting this case. It's extremely sad to see this, and of course, great to see how the clinical therapy has been applied. So if any of you have a question with regards to the case, please type in your questions into the question box. So the question box is located on the right in the GoToWebinar panel. And we would be happy to answer some of your questions. So far, we have not had any questions on this, but if you do get questions, please type them in. We're going to have another question and answer session after the first part of the lecture. So we would be able to address the questions as well during that time. But please do not hesitate to type in any of your questions related to the lectures or to the case study. Okay, Linda, I think we can continue since we don't have questions at the moment, and maybe when they have questions in the second part, we will then address them.
That's fine. So let's start with the cardiovascular system. So the heart arises from the mesoderm. Now, please remember that when the fetus starts forming or the little embryo starts forming, we have three sets of, it's in a tube and it has 3 layers. So we have mesoderm, endoderm, ectoderm. Endoderm is generally where your muscles are. Endoderm is generally where your skin arises from. Mesoderm is basically where muscles arise from, and ectoderm is basically where bones arise from. So the heart rises from mesoderm because, of course, the heart is going to end up as a muscle. It develops from two endocardial tubes, and it is fully developed by the 9th week of pregnancy. So you guys can understand, if we go back to the diaphragmatic hernia, why the heart ended up being pushed across and stayed there. The heart starts beating at about 22 days post-conception, and cardio circulation starts between day 27 and 29 post-conception. The aortic arch develops between the 4th and 5th week, and by the 11th week, the heart is fully functional and formed. But, and this is the very important part of remembering, that this is not as such a muscle. At this stage, it is more a tendon. Initially, the heart beats like that of the mum, but then by week 7, it starts beating at about 180 beats per minute, because a baby cannot create stroke volume. It can only take its heart rate up, and at this stage, it's beating quite fast. The umbilical vein supports oxygenated blood and nutrients directly to the heart. And lactose and glucose is the only fuel that the fetal heart can utilize at this stage. So it's very important that you remember that. After birth, it will be like the adult heart. It will then start utilizing long chain fatty acids to actually to feed the cells of the cardiac muscle. The heart grows rapidly during pregnancy. However, it only has a 30% contractile protein. Therefore, these babies can't create stroke volume, and it reacts more like a tendon. So let's look at fetal circulation. What happens? So just like, well, let's go here. So the two arteries will bring deoxygenated blood to the placenta, and the umbilical vein carries the oxygenated blood to the heart. So what it will do is the oxygenated blood now comes in through the right atrium into, into the right ventricle, up through the pulmonary artery, through the ductus, here's the ductus, through the ductus, and returns back to the heart. So there's no oxygenation happening during fetal circulation to the lungs, very, very little. The lungs are making a movement, and you can see that on sonar, but they are not inflated, and there's no gaseous exchange occurring. Where the blood mixes, or where the blood goes, is via the foramen ovale here, and via the ductus arteriosus here. So those two structures are open, and we get the mixing of blood here. Maintaining neonatal circulatory hemodynamics can be very challenging if you have an immature vascular system, and supporting all the other organs. That is very important. So let's have a look what we support. The heart and lungs support the head, support the liver, support the intestines, support the kidneys, and support the lower limbs. This system is very clever, because when it realizes that it hasn't got sufficient circulatory volume, or it hasn't got sufficient oxygenation, it will pull oxygenated blood from areas like extremities, like the gut, like the kidney, before it will pull from the actual biliary system, or the liver, and the brain. The parameters used to measure systemic blood flow is the BP and capillary refill, and urine output will tell us how well the blood pressure is to the kidneys. But remember that we have immaturity here of both the heart, the lungs, and the kidneys, and this will affect your tissue and end organ perfusion. So the gestational age of the baby will affect the cardiovascular physiology as the gestational age affects the maturity. Also, medication and hydration, and the hydration state may affect the hemodynamics and change it constantly. So what we need to understand, these changes will include preload. Preload is coming into the heart, contractility of the heart, afterload, leaving the heart, and diastolic filling. So when the heart is in diastole, it's filling properly. Hemodynamics will be affected by sepsis, persistent pulmonary hypertension of the newborn, asphyxia, and a PDA. The goal of blood flow is to continuously oxygenate the cells and remove waste products and CO2. Okay, so remember, at the end of the day, we are coming down to cellular level, and the central nervous system is very closely linked to the cardiovascular system. So oxygenation requirements of a cell is very dependent on how well the cell and the organ functions. The heart, brain, lungs, and renal cortex and adrenals all have high oxygen requirements, and the GIT and muscles can afford to lose oxygen supply and blood supply if necessary. So here, if you look at this, the oxygen comes in, sodium comes in, glucose comes in, and then the ATP system kicks in. The medulla oblongata in the brain will regulate the cardiovascular system via the central nervous system in a state of shock. So NEC often develops in the hypotensive phase when, if we go back here, there isn't sufficient blood pressure and the body decides to take blood from the lower extremities in the gut. That is when NEC decides to develop. Also, hyper and hypocapnia, that means oxygen exchange, needs to be prevented in the acute phase of disease, as this will also affect your cerebral perfusion pressures. So what happens at cord clamping? The umbilical cord clamping at birth results in major cardiac changes, which happens in minutes, hours, days, and weeks following. So while the baby is in utero, we have a right to left shunt, which means the blood from the right side of the heart shunts to the left side via the foramen ovale and the ductus arteriosus. The big changes that occur initially once we clamp this cord in the first 10 minutes is that we reverse this shunt and it becomes a left to right shunt. So what happens is there's pressure in the lungs that prevents blood from flowing to the lungs. So it must go via the ductus back to the circulatory system. The minute the baby breathes, we have a reduction here of pressure and the blood can flow into the lung. So remember, at birth, we're reversing the right to left shunt. The PDA remains open, especially for a few hours, but in the premi, for many days even, that can happen. And this affects the optimal closing time of, so we've got to consider the optimal closing time of this PDA if we want the baby to do well. The cardiac output determines the delivery of O2 and CO2 removal from the cell. So if this heart has got a decent pumping action and the output's good, we've got good blood pressure and we will get good tissue perfusion, which means that we'll have cell perfusion. The above adaptations are very difficult for any newborn, and for that reason in the premi even more. So this whole idea about cord clamping is very important because we do delayed cord clamping, allowing the placenta, remember, to empty out. We did this in the second lecture, to empty into the baby's circulation. Once we've clamped this cord, we only have a certain amount of circulation. So at birth, the newborn needs to increase its cardiac output by taking up its heart rate. And it can hardly create stroke volume. So for that reason, it takes up its heart rate. The immature myocardium has a problem with contractility. And this is where that article that I've just shown and pointed you to becomes very important, because what the doctors, the neonatologists are now doing is that when a baby so-called crashes, we are now putting a sonar probe to the heart to see if there's a contractility problem or an effusion problem, has a tamponade occurred, or what is the problem? Because this is where the main problem sits. If we do not have cardiac output, the baby cannot oxygenate properly, it cannot drive its kidneys properly, and that's where it starts to fall apart. The myocardium is also affected by calcium influx, and this is especially in the first few days. So the calcium in a baby often needs to drop. Remember that we don't always add calcium, we actually add magnesium, which pulls the calcium. Inotropes, if selected correctly, will affect the contractility. So what is preload and what is, so we're talking contractility here, which is actually preload and afterload. So preload, what comes into the heart, is dependent on your hydration status. Or if we go back here, when we clamped here, if we clamped too quickly, then the volume would be affected. So that would be the problem there. So the volume of the heart in the ventricles at the end of the diastolic session. It's increased. So preload's increased with hypervolemia, too much fluid, regurgitation of the cardiac vessels, and in cardiac failure. So these patients with edema, we've increased the preload. The afterload is the resistance left ventricle must overcome to circulate blood. So the resistance coming into the heart on the left side must overcome that, and it must push it out. So afterload's increased again by hypertension and vasoconstriction. So an increase in afterload will increase your cardiac workload. So the sick neonate, especially the preemie, can have reduced or apneic respirations with poor lung compliance, which results in a reduced thoracic musculature, which will affect this. So sick neonates, it can affect the pre and the afterload. Contractility, because of the interplay between contractility, preload and afterload, there may be changes in the cerebral blood flow. And in your preemie, this is when we get intraventricular hemorrhages. When we look at something like HIE, hypoxic ischemic encephalopathy, we will now have perfusion injuries to the brain. So it's very, very important that when we look at the blood pressure and we look at cardiac tracings, we realize where we are. So now there was a question, will we be covering the patent ductus arteriosus? Yes, we are. So the ductus is the opening between two major blood vessels leading to and from the heart. The pulmonary artery, remember, in the heart, from the heart, the pulmonary artery carries deoxygenated blood, and the aorta. So remember that when the baby is in utero, the actual oxygen perfusion is coming from the placenta. So what happens? The blood comes via the placenta into the heart. We get a mixing here of blood via the ovale foramen and the ductus arteriosus. So the blood is not flowing from here to the lungs to be oxygenated. It has arrived oxygenated. And so it then gets pushed via the ductus arteriosus back into the right ventricle, the left atrium, left ventricle, and then leaves. So the ductus, the blood flow here will be right to left. Initially, the PDA will close with pressures, and in time, it will become a little tendon that sits here. When we speak about the PDA in the NICU, we are often referring to a left to right shunt. Okay, so what this means is that the pressures now from the lung have altered, and the blood is now coming from the aorta back into the heart. So we're now getting oxygenated blood back into the heart. Okay, the blood flow from the aorta to the pulmonary artery causing a left to right shunt. This leads to the left atrium and ventricle overworking, because you can think for yourself that we haven't got a balance of the volumes. And so this left heart muscle, side of the heart muscle, has to work that much harder. So what are the risks for patent ductus arteriosus? Well, the first is prematurity, because what happens is very often in the prem, the duct is actually quite big because it's still coping and it's not responding. A family history, so family history and genetics will give you a ductus arteriosus. Rubella will give you a ductus arteriosus. High altitudes. We see more PDAs that are open higher up than we see at sea level. We see more ductus arteriosus in females. And this is because the prostaglandin hormone is involved in keeping the ductus open. We see a lot of it in RDS and in sepsis, or when there's low platelets. You see low platelets with sepsis. So remember that in utero, we will have a right to left shunt, but outside of utero, we most often see the left to right shunt. And this means that there's oxygenated blood being pushed back to the heart to actually reoxygenate. So this shunt can cause pulmonary hypertension because we're getting flooding of the lungs, because remember that we'll have an increased volume here. This is going to pump it to the lungs, and it can cause pulmonary hypertension. It also very often causes pulmonary edema or pulmonary hemorrhage. Very often when we see a pulmonary hemorrhage on a ventilator, it's because the duct is still open. It causes hepatomegaly because we've got fluid overload. There's a risk for NEC. There's a risk for renal ischemia. And it worsens BPD or bronchopulmonary dysplasia. What are the signs and symptoms of a ductus arteriosus? There's often respiratory distress and what we call flip-flopping. So these babies with open ducts, they very often tend to be a little bit apneic. They'll do well for 3/4 of an hour and then suddenly have 2 apneic spells. And that very often is when there's quite a bit of fluid being pushed through the duct right to left. So very often you'll hear the experienced staff say this baby's flip-flopping. There's a lowered immunity because it's not a decent interplay and the baby's a bit stressed. There's low weight gain, again because of the stress. You will see bounding pulses. Very often if you put your finger in the femoral area or on the top of the foot, you will feel these bounding pulses. And if you know how to look for a widened pulse pressure, you will see that as well. What is the treatment? The initial treatment is to fluid restrict. If that doesn't work, then we will look at closing it with a medication such as ibuprofen or paracetamol. Years ago, we used to use endomethazine, but endomethazine actually creates quite a bit of GIT irritation and can cause a gastric bleed. So currently, most people use ibuprofen or paracetamol, and they may even go as far as using the IV paracetamol. Or we can have surgical closure where they will go in and they will literally they would ligate there and there. This is a very tricky procedure, and one has to be very careful, and the surgeon really has to know what they're doing, because it's very difficult to ligate it. What is the nursing care for this baby? So we do need to look at positioning of this baby. It is best to keep these babies flexed, because that way you will improve the whole system of cardiac return. It is also symptomatic, so treating their apnea, giving them oxygen if that is what is required, and fluid restricting them. To support growth and development, because these babies will be working harder and their heart rates are up, they're going to need more energy, and we would have to perhaps supplement the breast milk with something like a protein supplement that goes into it, or adding calories in some way. And we have to reduce the baby's anxiety. From there, can we have the questions?
Thank you so much, Linda. Yes, we have a few questions which we are going to address right now. And again, in the meantime, if you do get any questions, please type them into the question box. And we will start with answering the first few questions. Okay, so the first question, please, can we explain the PDA pathophysiology in the NICU once again?
Okay. Let me just go back. The pathophysiology in the NICU. So what happens is the baby will be born, and then the whole system kicks in within minutes. So what should happen is, remember that up until the baby's born, there's a right to left shunt. If you do a blood gas right at birth, you will find that the baby is acidotic and has what we call a mixed blood gas. That is because up until the minute we clamp that cord and the baby takes its first breath, we've got the right to left shunt. Now the baby breathes and inflates its lungs, and we now get that blood flows to the lung and then returns via the pulmonary veins to the heart. However, what very often happens is that we give a bit too much fluid, hemodynamics are not working properly, and this little PDA is not a closure like that. It doesn't. It needs pressures to keep it closed. So you need almost equal pressures here and here to prevent the shunting happening, because that's what happens. Flip-flopping is shunting. So the pressures need to be equal here and here. If you do not give surfactant to a premature infant, you're going to raise the pressures here, and that is going to cause the shunt to happen. If you give too much fluid, you again raise the pressures here, and you will get the shunt happening. So that is what basically happens. And because the pressures are not equal, the shunt happens. But in most instances, it's what we call an idiopathic shunt. It's left to right. It doesn't do a lot of harm, except long-term you will develop BPD, but it doesn't create major harm because it's a left to right shunt. It's not the other way around. The other shunt is PFC or PPHN, which is the problematic one. This is a left to right shunt. It's oxygenated blood returning back to the heart instead of going to the circulation. I hope that helps.
Thank you so much, Linda, for going through this again. There's another interesting question. Is PDA related to maternal preeclampsia? I've seen a few babies when mothers have PIH during her pregnancy.
It is described, it is well described in PIH, and I think that one of the reasons for that is that those babies are stressed, and a stressed baby automatically will also secrete stress hormones, and that is often the reason why I think it will be open. Sorry, I do think that it is. I've also seen that trend. It does happen.
Excellent, thank you so much. Another question, when should surgical closure of PDA be done in neonates?
Surgical closure.
Yes, surgical closure.
Yeah, this is very debatable. If you talk to most nurses, they will tell you it's best to close it earlier rather than later. And I do believe that it should be done earlier, but a lot of doctors try and will give babies a trial of medication even 2 or 3 times before they go in and close it. The problem is by that stage that the lungs have become so flooded and had to work against that excess pressure and edema that we do see BPD developing in these children. In South Africa, generally, they will do the procedure from about day 14 to about day 21 to a bit later. But in most instances, I think that it is, and the literature shows that the earlier you close that ductus, the better. But a lot of, because it is a tricky operation, and you've now asked the question, and for that reason, I will answer it. It is one of those operations where the surgeon has to be highly skilled, because the size of the aorta and the size of the ductus and where the ductus is placed is very significant. I have actually had it where a doctor in error has ligated the aorta, and we are talking 10 years ago, but it is possible. That is one of the biggest risk factors, is that they ligate and you must understand that these structures are minute, especially in the microprem, and it's the microprems often that need the ductus ligation done. So, you know, one of your biggest problems is that the aorta could, or one of the other structures could be ligated by mistake. So you do need a highly skilled person to do this procedure, but it is best, even in literature, to do it earlier rather than later.
Thank you so much, Linda. Another question, how does paracetamol intravenous or an anti-inflammatory, such as ibuprofen, close a PDA?
So remember, and when we talk about the cyanotic heart lesions, we will cover prostaglandin. So for this duct to stay open, there needs to be some prostaglandin release. And the anti-inflammatory action of ibuprofen and Panado, I think they found it actually quite by sheer error that it inhibits prostaglandin, and that will allow that little structure then to become tighter and tighter and closer together, because what you will get is once it starts that you don't, so you get prostaglandin release, which will keep this open. But once you inhibit the prostaglandin, it will allow the structure to collapse on itself, and then you get far better equalization of pressures, and that will allow for it to close. It will then close within 4 to 5 weeks. It then becomes a tendon which keeps the aorta above the heart. It's a very significant tendon, this.
Thank you so much, Linda. And so we have one more question. Why some doctors don't give any treatment at first, especially if they consider small PDA?
I think because most doctors sort of are of the idea that if they restrict fluids, and if they restrict the fluids, they're more likely just to get that collapse or equalization of pressure, and that will allow it to close. It is actually easier to hear a small ductus versus a big ductus. A big ductus, and I've seen this before, if there's a big ductus here, the whooshing that occurs here sounds almost aortic. And then with a lot of pressure, the doctors go, okay, we'll do an echo, we'll check. And then when they do the echo and the ultrasound, they suddenly see, but this is a very big ductus. Then you don't hear the ductus that much. So when it's a small ductus, the doctors go, oh, well, if we reduce the fluids, then the pressure should equalize and it should close. That sometimes doesn't work. And as you saw, females are at higher risk because remember, prostaglandin is something that we secrete during delivery and that we need in the months going up to the delivery because that allows our muscles to relax.
Excellent. Thank you so much, Linda, and thank you everyone for your great questions. Okay, so we have one more question. How long should neonates be prescribed ibuprofen for PDA treatments?
Oh no, it's only written up for 3 days, depending on, it can be broken up in doses or given daily for 3 days, but it's only done for 3 days. And in that time, if you use ibuprofen, please be very mindful of the gut. Monitor the gut quite easily. Ibuprofen doesn't cause the bleeds that we used to see with indomethacin, but it can have that problem. And it's important that we watch it. What I have seen pediatricians do, not neonatologists so often, is that they will give a 3-day dose and then they'll wait 4 or 5 days and repeat the dose if that duct hasn't closed. But sometimes it works, sometimes it doesn't. So it is important that we make sure that we actually understand that it can be problematic.
Okay, thank you so much, Linda, for answering this question.
There we go. So now we're going to talk about persistent pulmonary hypertension of the newborn, or what used to be known as PFC, which was called persistent fetal circulation. And this is now the right to left shunt. So we get the blood that continues like it would have done in utero, flowing from the deoxygenated side into the oxygenated side and across there. These children can be very, very, very ill. Pulmonary hypertension with reduced pulmonary blood flow is a normal physiological state for the fetus. So initially these babies can cope, but remember that the minute that we clamp the umbilical cord, these babies no longer have the placenta, which is oxygenating for them. So now we're getting true deoxygenated blood coming in here, and to go to via the pulmonary arteries to the lung, and then to return back via the pulmonary veins. Okay? That's what it should be doing. But in pulmonary, persistent pulmonary hypertension of the newborn, we get the so-called deoxygenated blood coming down, going via the foramen ovale, and then mixing here and mixing there. So these babies generally will have a low PO2 on blood gas. Please note something, that when the blood returns from the heart via the pulmonary vein to the left atrium and left ventricle and up through the aorta, it comes off, this is preductally. These two veins here are preductally. Just remember that. So persistent pulmonary hypertension of the newborn is described as a failure of the normal circulatory system to establish after birth. This also means that the baby's circulatory system doesn't adapt to breathing unable to establish decent respiratory or gaseous exchange. So the baby can't exchange gas. Usually it occurs after 34 weeks of gestation and it's triggered by other respiratory problems. So something usually in the lung field has caused this to develop. It's very common, not very common. You do see this mostly in babies that are post-term. Those babies that are born that have that green tinge to them and the yellow nails from the meconium that they've passed in utero. The big baby, the very dry skin, cracked baby, that's the baby that very often develops PPHN, because those babies have been in uterus for so long that the vasculature here is causing the problem often, it's thought. So what are the risk factors? The risk factors are meconium aspiration syndrome, or MAS, very common for a baby that's really had big meconium aspirations to actually develop persistent pulmonary hypertension. Sepsis can do it. Once again, we've got that whole cascade that happens in sepsis. Remember the cascade of the anticoagulants, etc. That can do it. RDS in a severe form can do it. Hypoxia before or during birth. And these babies that I've described to you with that greeny tinge and the yellow nails, the very dry skin, they've often had hypoxia even before birth. And they've passed that meconium in utero and they've been lying in that meconium for a few hours. As I said, congenital diaphragmatic hernia. So they can also go into this because you've got no lungs. So you will have raised pressure here because the blood supply is still there. That will give you a persistent pulmonary hypertension, as well as the infant of a diabetic mother. So those are the babies at risk of developing PPHN. How will we diagnose this? So this is what you're going to do. Remember what I said here about the duct and the pre and the after, the preductal and afterductal. So how do we confirm it? By placing a saturation probe on the right hand, ensuring you've got a good tracing, looking at what it is, and then placing it on the left hand or on the baby's feet, and then you can compare the reading. And what you will see is from the right hand, you will have a higher oxygenation reading to what you would see on the left hand or the feet. Now, there's something very important that you must remember here, is that because these two vessels come off before the ductus, preductally, it is brain sparing. So the O2 to the brain is still decent, but you're going to not have that to the other organs. And this is the one that comes off for the right arm. So the left arm is postductally and the lower extremities are postductally, but the right arm is preductally. You can also do a blood gas via the umbilical arterial catheter and the right hand. So what you do is that the person doing the umbilical catheter will attach the syringe and wait. And the minute that the person who does what we call in South Africa the right stab, or goes into the artery here, very often, the minute they've got in and they can draw back, you both draw back at the same time. You run both blood gases and you will see a difference in PO2 and CO2. And that will tell you whether you have got a PFC. Both methods give a preductal and a postductal reading. How will we diagnose persistent pulmonary hypertension of the newborn? We'll do it via chest X-ray. We'll do it via blood gas. We'll do pulse oximetry. We can do an ECG and a cardiac sonar. So those would be the ways that we would diagnose it. And very often with a cardiac sonar, they will use a color sonar, and you will see this mixing of blood occurring here. How do we treat it? Well, they often use oscillation or jet ventilation, so very fast, short breaths that allows it. And remember, the oscillation is different to normal ventilation because oscillation has a positive phase. So the inspiration and expiration are positive. And that's one of the reasons why these babies do warrant oscillation. They can use nitric oxide, which relaxes this vasculature bed here and allows for better oxygenation. And when it's a true true persistent pulmonary hypertension, and you start putting in the nitric oxide, it's actually quite phenomenal. These babies pink up very, very quickly. We can use inotropic support, and we will give them antibiotics. What happens with the nursing care? So you've got to ensure good oxygenation, and very often these babies actually have to be left prone because that way you get the best utilization of your lung field. And if you remember when we spoke last time about atelectasis, do you remember that we said that blood will go from the atelectic little alveoli to other areas in the lung? And this is why it is important in this condition to optimize positioning and get decent oxygenation. And very often it is by placing these babies prone. Maintaining the blood pressure with inotropes if needed. And definitely these babies must have minimal handling. Do not give these babies to a new, inexperienced nursing staff member, and ensure that this person who looks after this baby is comfortable to leave this baby alone. Because I can promise you, in a true persistent pulmonary hypertension of the newborn, if you just touch that baby or try and move its arm, it will desaturate. Inotropic support with dopamine, dobutamine, and or milnacone is frequently helpful in maintaining adequate cardiac output and systemic blood pressure while avoiding excess fluid. So these babies, you cannot fluid overload. Okay. Although dopamine is frequently used as a first-line agent, dobutamine and milnacone are very helpful. In actual fact, the research shows that it is better to start with dobutamine and going to milnacone than it is to start with dopamine, because one of dopamine's side effects is that it can worsen your pulmonary hypertension. So in South Africa, very often, a lot of the neonatologists will start with dobutamine first because they're trying to avoid this slight side effect of pulmonary hypertension. It is very important in these children to please ensure that there's pain and anxiety relief. It is very hard to breathe for them, and they will be anxious. The adverse neurobiological impact of pain and stress in a preterm infant has been well documented and imaged, and there's the article for you. And it is very important that we use both non-pharmacological as well as pharmacological methods. Your non-pharmacological methods would be things like proning this baby, ensuring that when you look at this baby, it looks comfortable. These babies are sick for 4 or 5 days at a time before they really start turning the corner. They become quite edematous. They become difficult to handle. And if you're allocated these babies, you actually need a buddy that can help you, because these babies need 4 to 6 hands on when we are going to work with them. and ensuring that they look comfortable, because they need to lie like that for at least 4 hours on end, is very important. So using your props, your pillows, your rolls becomes very, very important. Also ensuring that these babies, they are often given paralyzing agents. Some of the paralyzing agents cause excess saliva. You've got to sort for that. So please, non-pharmacological methods are very important. These babies do best with somebody who's very stable. You must include both sedation and analgesia cover. Very often, the doctors will give a paralyzing agent such as Esmaron or Pavilon, and rocuronium, or I can't think of Pavilon's name now, and they will give dormicum or midazolam, but they won't give analgesia cover. These babies are sore. They do need analgesia cover. And guys, please, at least once a day, stop the analgesia, the sedation, and the paralyzing agent so that you can see whether this baby is responding. The minute you see it move or twitch, give it its medication again. But be very careful that you actually see whether it is moving. What are the non-pharmacological methods? As I said, positioning would become important. And then placing things like bonding squares. These are the bonding squares that we have. They are made from cotton because cotton super absorbs smell. And mom wears one as a breast pad. When she gets to the hospital, she will literally place it here. Now, you guys all think, well, what does that help? I mean, really, are you mad? No, I'm not. Because mom's breast milk, her skin, and the liquor or amniotic fluid smell the same and taste the same. And actually, baby will be able to smell that and hopefully orientate or think mom is there. One of the other items that is very often used are these octopi to be put near the baby. It can also be worn by the mum to bring the smell in. Just remember that if you are going to use it, and the research isn't good on it, but it helps the parents, it soothes the parents very often, is making sure that the tentacles show upwards so that the baby can have contact with it. Obviously, when this baby is severely ill, nothing's going to help right then and there. But once the baby is born, once the baby starts weaning, you can start using it. Now we are going to go into congenital cardiac lesions. And in a country such as South Africa, congenital cardiac lesions are problematic because we literally have 2 or 3 centers that can operate on these children, and these children have to be moved to a unit appropriate for them once they have been diagnosed. Very often babies will die because they don't get treatment early on. So congenital cardiac lesions happen in 7 to 9 births of every 1,000 births. Luckily, most of these will be non-cyanotic ones that will not be problematic. As I said, about 25% are life-threatening. It may present acutely or in the critically ill child, and we break it down into cyanotic or non-cyanotic or acyanotic lesions. Cyanotic lesions means that the baby appears blue, and these are ductal dependent lesions. In the cyanotic lesion, the PDA plays a life-saving role and may require prostaglandin to remain patent. Okay, so remember it's there, and we try and keep it open. These lesions will be your transposition of your great vessels, your pulmonary stenoses, pulmonary atresias, mitral atresias, and coarctation of the aorta. Congenital cardiac reasons, you do see something called the cardiac collapsed baby. And these babies are broken down into a critical acyanotic heart lesion or critical cyanotic lesions. They can have dysrhythmias, or they've got an acquired cardiac disease. So there is a little bit of work now coming out talking about this in one or two of the premies that have been severely affected by COVID, that they get a cardiac, they get like a cardiac component to it. It is also described in the younger child and definitely described in the younger adult that we see with COVID and acquired heart disease, where we actually get cardiac myopathies. So very often, my experience is that about 2 out of 3 cardiac lesions that are delivered and born into your unit will come via the door with a nurse running in from the labor ward going, sister, or nurse, this patient's collapsed. And it's very often these critical cyanotic heart lesions that suddenly present that way. So how does congenital cardiac disease present? There's dyspnea, there's persistent tachypnea, which must make you think. They may be difficult to get off a ventilator. There'll be poor perfusion, cold, clammy, mottled extremities. They remain acidotic. There's decreased urine output, and on X-ray you may see that there's a cardiomegaly, so the heart is increased. They can present with cyanosis, so that you just can't get those saturations up above 90. And that's often after the first 2 hours of you delivering, a baby delivering and coming into intensive care and stabilizing, and you just can't get that oxygen up. That's the bell that must ring. Is this a cardiac baby? And when you mention that to the doctor, the first thing they're going to ask you is for 4-limb BPs. That's what they do standard. They have differentiating saturations from the right arm. So if you put the sat probe on the right hand or arm, you will see that the oxygen is improved via the left. And that's often indicative that your duct is functioning. You'll diagnose it by chest X-ray, ECG, cardiac sonar, and cardiocath if you've got access to that. How do we look after these babies? So we need to keep them calm and comfortable as possible. Interestingly enough, these babies do better in a slightly cooler environment. They must be handled minimally. There's strict intake and output. These babies, you do need to weigh the nappies, catheterize the babies, or however you determine fluid output, because that's going to become essential. You must maintain your critical infusions. You cannot, with these children, actually stop a pump to change fluid, because stop a pump to change an inotrope, because they will crash on you. Maintains, as I said, allow skin to skin where possible, if possible. Optimize nutrition. And remember, as I said, that they do actually do better with a slightly lower temperature. So how is it classified? We get cyanotic lesions, which have decreased pulmonary flow, which are your tetralogy of Fallows. Tetralogy, there's 4 problems there. Tricuspid atresia and univentricular hearts with pulmonary stenosis. Your increased pulmonary flows are your transposition of the great arteries and total anomaly of the venous return. Your acyanotic heart lesions, these babies generally do better. Ventricle septal defect, VSD, atrial septal defect, ASD, atrioventral septal defect, so there's a problem between both. Patent ductus arteriosus, aortic stenosis, pulmonary valve stenosis, and coarctation of the aorta. So let's look at the cyanotic lesions. Let's look at what is tetralogy of fallows. So there's 4 problems. There's pulmonary thickening or pulmonary problems coming back. There's a thickened ventricle. There's a ventral septal defect. You can see here, look here, there it is. And the aorta has a problem. So tetralogy of fallows, we see this very often. These babies last for a long time. They're often not diagnosed in the neonatal phase. We will pick them up later. In South Africa, very often these babies come from the rural area and they've survived for so long because they learn to drink their bottles with their feet. They will literally hold their bottles with their feet because that improves their cardiac return and they do better. They just do much better. Tricuspid. So what do we have here? There's an atrial septal defect. The tricuspid valve hasn't developed, so the blood flow is there. And there's a ventricle defect. So here's the normal heart. Can you see? Right atrium, tricuspid valve, right ventricle. Look at this one. There is no tricuspid valve here. And so they're using the atrial septal defect. So there's an opening between this heart chamber and that heart chamber. And there's one here. So there's an ASD, a VSD, because there isn't a tricuspid valve here. So what would they need to do? They would need to do surgery there and then later correct that. Transportation of the great vessels. So what are we seeing here? That things aren't what they normally should be. So the aorta now emerges from the right ventricle. The pulmonary artery emerges from the left ventricle. There's usually a septal defect and an atrial defect, and we will need a patent ductus arteriosus. Okay? So the ductus needs to be open for this baby to survive. So here we have the normal heart, and look at this one. Totally and utterly different. Where did this go wrong? Probably in week 8 to 9 to 10. You can see how much different it is there. Hyperplastic left ventricle. This baby, these children generally are incompatible with life. They are often treated with palatal care. So what do we see in the normal heart? There it is. In the hyperplastic left lung, what will we see? Left heart, what do we see? So we have these normal structures here. However, we don't have a very good ventricle developed here. On X-ray, very often this heart, this muscle will already be quite enlarged. And if these babies are diagnosed towards the end of pregnancy, the parents are offered palliative care. Now let's look at the cyanotic lesions, the acyanotic lesions. So these lesions, there's blood mixing, but it doesn't make the baby blue. It doesn't overstress the baby. So pulmonary stenosis, once again, here's your normal heart. And where's the problem? There. So there's a narrowing here. So what will that narrowing cause? We will see an enlarged heart muscle on this side. Okay? Because there's a stenosis here. Mitral valve stenosis or atresia. So that problem sits here. Either we don't have a mitral valve, or we have a stenosis, or it hasn't developed at all. But it's on the oxygenated side of the heart. Coarctation of the aorta. So let's look at this. Where does the problem sit here? There. So there's a narrowing in the aorta there. And that is going to cause a problem because we're going to get a narrowing here. So we're going to get the development of pulmonary hypertension. Congenital cardiac care, we need to definitely here give family-centered care because often these children are sick for a very long time. If there are siblings involved, siblings will feel pushed out because these children are very sick and these children get all the attention and the others do. So we have to support the parents by explaining the situation as simply as we can. We have to answer the questions truthfully. Please, you know, parents get given hope and very often it leads to large disappointment later. It's very important that parents get enough information and that they can make an educated decision. Allow parents as much access as possible. If you can, encourage the use of a journal. What we suggest is that every preemie, every baby with a cardiac lesion or a life-threatening disease, the parents should start to journal as early as possible. They can keep their personal journal or they can have a journal in the unit next to the bed where staff can participate, where you can put the odd photograph for them or a footprint in, or in times when we didn't have COVID, if we allowed grandparental visits, they could write a little note. It is important to start a journal for these babies because very often the outcome is dire and all a mother will have is a journal. Document as much as you possibly can, and here I mean both by what you write in the notes, but also giving the parents as much information or info as you can. And here I need to address this whole developmental issue. If you are going to go and restrap an ET tube or an ET tube has come out or you have removed the baby from ventilation and you're going on to CPAP, please consider just doing a photograph before you re-put in all the pipes and all the equipment back on that little face, just so that they've got that picture of that baby's face. Because to a parent, a face with no tubes and plasters just gives them an idea of what the features look like. And some parents have one photograph, if you're good at it, to hang on to. It will take you 2 seconds to do that photograph, but you do not understand what it means to that parent to see that little face without anything on it. Now we're going to talk drugs. So prostaglandin. Prostin E is a natural occurring prostaglandin with oxytocic properties. So it can calm people down. It is used to keep the PDA open. It allows for the child to stabilize prior to surgery and for surgery. It maintains the PDA in utero, okay? So the mum secretes prostaglandin throughout her pregnancy, keeping it open. And exogenous prostaglandin is given orally or IV to keep the ductus open if there's a cyanotic heart lesion. And you know, a lot of doctors think that you can only give IV prostin. In Africa, oral prostaglandin is often given for weeks on end, hourly, to keep it open to get a child to a center for care. Prostin E is metabolized via the lung and excreted via the kidneys. The dose is 0.05 milligrams per kilogram per minute. And during surgery, it may cause fragility to the PDA, the pulmonary artery, and the aorta. And this is a problem because it can cause severe bleeding in theatre. When given, there should be an improvement of the SPO by about 10%. So when it starts working, you will see, and the duct opens, your saturations improve between 8 and 10%. And usually we will keep these saturations between 80 and 90. What are the side effects of prostaglandin? Well, there's vasodilation. There can be apnea or hyperventilation. They are jittery. They can develop a pyrexia, and they can have diarrhea. Please be aware that long-term it can cause a rupture of the ductus arteriosus. And the only reason why it would cause a rupture of the ductus arteriosus is that the pressures on either side or one of the sides becomes problematic. And then the rupture occurs when the blood starts becoming problematic. Once again, remember that when we spoke about the congenital diaphragmatic hernia, I said to you there's this move now to utilize a lot of cardiac visualization via an ultrasound in acutely ill children. This is one of the diagnoses that would be picked up. Which cardiac lesions require prostaglandin? Well, it will be a pulmonary atresia, pulmonary stenosis, tricuspid atresia, tetralogy of Fallot, and coarctation of the aorta. Dobutamine, also known in our country as Dobutrex, it's an inotrope to treat cardiogenic shock and cardiac failure. It's a systematic vasodilator, and it stimulates the beta-2 receptors, causing vasodilation. It increases cardiac output, blood pressure, and heart rate very quickly. The minute that it's in the system, you'll see the heart rate go up. The dose is 0.5 to 1 millimole per kilogram per minute, and it's given as a continuous infusion, and you can go to 20 mics per kilogram per minute. Not in cardiacs, but in septic shock, by the time we get to about 12.5 to 15 mics per minute, we would consider adding adrenaline. Dobutamine, its interactions, be very aware of dobutamine because it interacts quite easily with a large range of drugs. So it is best suggested that in your unit you have a list of the drugs it interacts with, so that you can rather give this through a separate line, ensuring the optimal use of dobutamine. Its side effects: tachyarrhythmias, so it can cause an arrhythmia, hypertension, myocarditis, angina, dyspnea, fevers, headaches, nausea, and palpitations. Dobutamine should raise your heart rate within 10 minutes of administration. It has a half-life of 2 minutes, and it's excreted via the urine. It is incompatible with what we call a bicarb cocktail. It is IV compatible with dextrose saline, dextrose water. And please use a main vein to administer this. It should actually be given via the umbilical catheters or via central line, because it can cause problems peripherally. But if you don't have that, you don't have that, and you have to go that way. I do have to talk to you about when you start using inotropes. You will see that in most inotropes can go into both dextrose and saline. If your baby has a higher glucose, but the sodium is normal, it is best to mix your inotrope in a saline mixture, because every time we add extra dextrose, we put extra stress on the endocrine system to get rid of that dextrose. And remember, and we will be addressing that in, I think, 2 lectures time, that in actual fact, you will need increased insulin secretion to deal with. So say you have a glucose reading of 8. Then it is 8 millimoles. Then it is far better to mix your dobutamine and saline if your sodium levels are normal, because that baby won't need to actually oversecrete more insulin to deal with the dextrose. Because remember, dextrose works on the kidney as well, so it's dehydrating to a baby. Now that we finished that, I am going to cover transportation of the critical newborn. And I need you guys to understand that there's a reason why we have put this together. For 8 years, I flew for the medical company or the hospital group I worked for, and the most transfers I ever did was cardiac problems. And what I found is that very often we battled with regards to how we dealt with these babies. So what should happen is that when you make a call to an air service or an ambulance service to transfer the child across, make sure you've got as much information as you possibly can. This makes the planning of the actual transfer far, far easier for the person who has to come. Because if you have palpitations from transferring a neonate from your NICU to theatre, just know that the person coming to transfer this baby from your NICU to a upscaled NICU is also going to have far more palpitations than you've got. So giving them as much information as you can is very, very important, because it takes very carefully planning, and one needs to have as much information as you possibly can. If you're in a rural area and there is a problem with oxygen, let them know, because they'll have to bring extra oxygen. If the baby has multiple infusions, you must know which infusions are there so that the staff can make an educated guess as to how they are going to deal with those infusions. Because you can see just from this picture here, they've already got 4 pumps up here. And also, so there needs to be a conversation between the dispatching hospital, the receiving hospital, and the staff doing the transfer. Because that way there's very clear indications what's happening. You cannot assume, if you are the dispatching hospital, that a mother could accompany the patient. Because if you look at this tiny helicopter, we've already got, this is probably the nurse, and this is probably the paramedic or the doctor, and then we're still going to have 2 pilots because that's what's required. There is no space after this system has been slid in for anybody to go with. It's an impossibility. These are generally the type of helicopters used throughout South Africa. They have a range of about 400 kilometers if they can refuel on the other side. Otherwise, it would need to use a fixed wing aircraft. A fixed wing aircraft also has problems. There may not be space for the parent, depending on the type of equipment that they have to bring and take and fly with. So it's very important that as the dispatching hospital, you give them very good information. because the whole object for the flight staff is to keep this baby as stable as they possibly can. So prior to collecting, what should you do? Give a very clear and concise history. Make sure that they know what they're coming to collect. Also let them know what they may require. Do they need to cool this baby? Do they need to heat this baby? Are there multiple infusions? Is there perhaps an open abdomen? That all needs to be put through to the staff. Also what the baby's needs are, and whether a parent can accompany or not accompany. But now you're going to have to check twice, because you have to check with the service as well as checking with the receiving hospital whether they can accommodate that parent. Because you may have to not send the parent, but you may have to send a cooler box of breast milk. Ensure that the baby is as stable as possible. And this is sometimes very, very hard. Replace the IV therapy if it's necessary. Please label the lines so that the staff know what is infusing where. Replace the ET strapping, the endotracheal tube strapping, if the baby is intubated. This may not be necessary if you know the air service coming and that they prefer something called halter strapping, or if you do halter strapping, this might be the best way to secure this airway is with halter strapping. Replace the ECG leads, and please, if possible, put a plastic dressing over those ECG leads so that they're stable in air, because very often if the ECG leads aren't sticking properly, it will give them a poor reading in air, and that is problematic. Strap in any lines that you can, and they may elect to only do essential infusions. So if I say essential infusions, they will maintain the arterial line, they will do the inotropes, they won't take the TPN because that's not necessary. It can be restarted on the other side. They can take it with them, but they won't call that a necessary infusion. Sometimes they will stop the sedation, so the morphine and midazolam, they will prefer maybe to do those as boluses in the air. They may elect to just run a basic fluid because it is very difficult to keep all these syringes going. On collection, make sure that you have written a detailed handover report. Pack the baby's requirements and feeds as needed. Please suction the baby well. And one of the areas where we do need to suction is the nasopharynx, because remember, they're going to battle to suction this baby in utero, in air, so they need to do that very carefully. Change all the infusions first. So if they decide that they say to you, well, we're going to use syringe drivers, you will change the infusions prior to moving the baby. And please prevent that spaghetti that occurs, because if you've got an emergency in air, sometimes, you know, in a helicopter, you can call for them to land. You cannot call for them to land fixed wing, and some road transfers now are also problematic. And if possible, allow the parents to hold the baby prior to the staff arriving. Document the observations prior to you starting the transfer from your bed to their incubator. You transfer the baby last. So you do everything else before you transfer the baby. Allow the baby to stabilize in the unit. So Margarita is going to talk to you about the Dräger Incubator, which has a ventilator on board. I like to leave the baby on that ventilator for 5 to 10 minutes to see it stabilize before we will push it outside the door. Document the observations as the baby leaves and let the staff sign for both the baby and the documentation. And now this I have to say, because in Africa we have quite unique situations. Prior to COVID, if we were going to move a baby, what we would often find is by the time we push the baby out the door to the ambulance, we could have up to as many as 50 family members waiting to get a glimpse of the baby. This can be very daunting for any medical staff pushing the baby through. And so a clear exit is very, very important. When the baby has left, phone the accepting unit and hand over to the staff member who is going to take that baby. Ensure that you explain to the parents throughout what is happening, and please keep them updated throughout the transfer so they know what's happening, they know who's coming, they know what to suspect. And I've given you a link there to read. And just to finish today's lectures, and we virtually on time, these are where you can go and look for further help with regards to where you want to be: the European Journal of Pediatrics, the Cochrane reviews, and NEO papers. A lot of the papers I have put in today's lecture have come from NEO papers, and you can literally just copy the link and you will be able to get the paper. And that's it, Margarita.
Thank you so much, Linda, for this excellent lecture. I think you have covered a lot of topics today, and the questions that we're getting actually showing that we've covered the important topics. So thank you again for an excellent webinar. And now we are opening the floor to questions. So if you do have questions, please type them into the question box and we will address them. So we have received a few questions already. The first question is a bit long, so I will try to read it out as clear as possible. Regarding positioning of the preemies, babies after surfactant is set to prone position, is good or even ideal one. Does it not contraindicate even if the babies have umbilical catheters in place, like UAC or UVC? Because of the fear thinking it might cause a problem, we do prone positioning after the takeout umbilical catheters, and usually after 1 week. Thank you for clarification.
So I don't know how they secure their umbilical catheters, but if you're using a plastic film dressing, the catheters will be well secured and flush with the skin, which makes turning them prone actually quite easy. A lot of hospitals don't want that done because there's this fear of the catheter being removed or leaking. A decent monitoring system will immediately tell you that is happening. But proning the baby for the use of and getting the surfactant through is quite important. And I think often we have to think out of the box of securing those umbilical catheters. So what I know we do quite often is we will fold the plastic dressing prior to applying it, so still keeping it sealed as such, well, taken out of its sterile packet, but we will fold that dressing and then we will cut a little hole centrally in the middle and put that over the umbilical area so that it's the umbilical the umbilicus actually can dry, but that the catheters are then sort of put in a circular motion under that dressing and secure that, and that will help a lot. That is quite important. But proning does give you better lung usage, and I think one just needs to be quite creative in the way that you do it.
Excellent. Thank you so much, Linda. There's another question. Please repeat the explanation for quick confirmation.
I take we're talking here about we're talking about the ductus arteriosus, and we're talking about PFC. So I'm going to explain it to you again. So if my system, there we go. So remember that it's a right to left shunt, and that the blood is going through the foramina ovale and from the pulmonary arteries there, okay? That we have these two off flows prior to and the others after. So what does it mean? That when we go to do the actual test, we are going to do a test on the right-hand side, which will tell us preductally, so what the oxygenation to the brain is like, and postductally. So we'll start with the SAT probe. Make sure the hand is warm, put the SAT probe on the right hand, and make sure you've got a decent tracing of your saturation. See what that number is, then change it over to the left hand or the feet, if the feet are warm. Very often in PFC, the feet are cold. So try the left hand, and you should then see a difference of about 10 in the saturation. When you go to do the blood gas confirmation, you're going to use the right arm, probably brachial or at the wrist, and you're going to use your umbilical artery catheter or the left arm. And when you have both managed, well, hopefully an umbilical artery catheter, so this person here will actually be ready to withdraw when this person here hits the artery and is able to get the blood gas. So you get two blood gases at the same time. Again, this will be postductally, this will be preductally, and that's how you will get that info out.
Excellent. Thank you so much, Linda. Another question, I think, of clarification. The transportation of great arteries, is it the same as the transposition of great arteries?
Yes, it depends on which books you're reading. So transfer and transposition of the great arteries are the same. One is an older term to the newer term.
Another question, I would like to know the mechanism of a PPHN for neonates of a diabetic mother.
Can you repeat that?
I would like to know the mechanism of the PPHN for a neonate of diabetic mother.
Sure. Okay. So remember that in the diabetic mother, there's a few problems that develop with the infant of a diabetic mother, because the mother, especially if her glucose is not controlled, it is usually a large baby, and a larger baby will give you larger vasculature to the lung. So that's number one. Number two is that these babies become quite stressed because the minute they're born, they start losing their glucose control, and they become hypoglycemic very, very quickly. And also, we seem to think that because of the higher glucose, the blood is more sticky. They often run high HBs or hemoglobins, and if they do an ESR, if you were to stand the blood and let it separate, you would see that you have a much higher red blood cell concentrate to the plasma, and that in itself can be problematic on a lung field. So they often run high hemoglobin levels, often between 18 and 20. They battle with this very sticky sort of blood. It doesn't move easily. It's not easily movable, and that all becomes a problem, and it adds to the PFC.
Excellent, thank you. Another question. Any suggestions about placing neonates on a right lateral position and cover the left chest with a gauge in PPH and PDA neonates? I have seen one neonatologist practice this method for all his PDA, PPH, and neonatal patients prior to transfer to other hospitals for further management.
So he's placing them right.
Yes, they're placing them on the right lateral position and cover the left chest or left side.
So the reason why he would do that is that, remember that in any cardiac lesion, even in something as simple as a PDA, you will have hepatic megaly. So, and you will be able to, at any one time, if you were to examine the baby, if you all know where the diaphragm is, if you slip your fingers on the right side of the baby, just under the diaphragm, you will literally be able to do what we call tip the liver. You will feel the liver edge there. Now, generally, if you sort of go just sort of half a centimeter to a centimeter below the diaphragm, you will feel the liver there. That's normal. But in children with cardiac problems, and they often are, there's obviously because of the circulatory issues, there's a problem. You get hepatomegaly, and you will be able to tip that liver between 1 to 2 to 3 centimeters. Now, if you lie the baby on its left side and the liver is enlarged, the liver is now going to push against the intestines and push up against the inferior vena cava here. So your cardiac return would be affected. If you turn the baby on its right side, what you're now getting is that the liver will almost flop outwards and improve the inferior vena cava return, if that makes sense to you. And that is possibly why he is doing that. I have to say that there would be a follow-up problem to that, is that you'd have poor absorption of feeds if the baby is stable enough to get feeds, because traditionally the baby will feed better on its left side. There's another reason why he's doing this, interestingly enough. It would be that, remember that your right lung has 3 lobes. Your left lung has 2 lobes. And by putting the child on its right side, you would get improved oxygenation of your right lobes. So he's looking for improved. So if we were to go all the way back here, what he's doing is the following. He's improving his preload and he's improving his oxygenation, if that makes sense.
Okay, thank you so much, Linda. There's another question. When do the PDA close?
The PDA should close between 12 and 24 hours post-delivery in a normal infant. In the preemie, the late preemie, it can be similar to about 48 hours. My experience with the micro preemie is that it takes much, much longer. And for that reason, we have to use initially pharmacological closure and if need be, go to surgical closure.
Okay, and another question, does delayed cord clamping cause polycythemia leading to hypoglycemia?
Yeah, it does. And it doesn't just cause polycythemia. And for those of you who don't have English as a first language, polycythemia means that there's excess red blood cells. So when we read the HB, it will be between, generally it's usually between 16 and 20 grams per deciliter. And that would be considered polycythemia. Polycythemia has two problems. It can cause sluggish blood, so a lowered blood glucose, but it also, and that's the biggest problem with the laid cord clamping, it leads to increased jaundice, because remember that you need breakdown of the red blood cells for things to improve. And so you do see this jaundice that occurs in these babies. It's generally not a problem. They need some lights and they generally do very well. But the two problems with the delayed cord clamping can be polycythemia with low glucose generally and a higher bilirubin reading.
Excellent, Linda. Thank you so much for today's lecture and today's webinar. I think we have covered quite a lot of topics, and so far we have answered most of the questions. So what we are going to do, we are going to start with the practical demonstration of a transport incubator. Let me just, perfect. So of a transport incubator, GT Globe Trotter 500. So it's going to probably take no more than 15 to 20 minutes, maybe a bit longer. And then after that, we're going to have another session for questions and answers. So if you do get any questions in the meantime, please do not hesitate to address them in the question box. So we will have another question and answer session. So without further ado, I would like to quickly take you through the transport incubator. And I think Linda has highlighted the importance of the transport, especially for the preterm infants and also for the high-risk preterm infants with cardiac issues. And of course, we know that in the clinical settings, we sometimes transfer our patients in cots, in open care warmers, we transfer them in just bassinets. So in the hospital environment, usually the transfer happens quite short. So the distance between L&D and the recovery and the wards is quite short for the NICU. But when it comes to neonatal transport, we have to really ensure that we are providing the right settings and the right environment to protect the baby. So basically to offer a thermoneutral environment and also to offer the appropriate respiratory support. And I think Linda has also mentioned that she prefers to keep the babies in the transport for at least 10 to 15 minutes on the ventilator. And of course, we don't talk about the high advanced ventilators that we have in the NICU, like we addressed last time, baby Lopian 800 with high frequency ventilation. No, of course, we are talking about a solution that will maintain our baby's lung stable and that would offer a stable thermoneutral environment during transport. So today I would like to demonstrate a Globe Trotter 500. Globe Trotter consists of a transport incubator, so the TI 500. We have the control parameters for the incubator, and we have the neonatal reanimator, which is called Stefan 120. And in our portfolio, we have various transport incubators. So we have also the GTIC, Globe Trotter IC, which has a different type of ventilator, but the model and the concept is quite similar. And the idea is that, as I mentioned, we are offering stable and lung protective ventilation that is humidified to the patient that requires transport. And we can have a look a little bit closer. So this is the closer view of the ventilator. So we have the main turn on off button here. We have the pressure gauge that indicates the pressure. We have the gauges for the oxygen supply from the wall and for the oxygen supply from the cylinder. We have the possibility to monitor the FiO2. So basically we can turn it on and off. We have the alarm settings for the oxygen, for the FiO2. This is our oxygen cell. So this, see, just demonstrate to you. A bit lower. So this would be our oxygen cell. So this is the cell that is responsible for measuring the FiO2 concentration. And then we also have the settings for the inspiratory time and the expiratory time. So we don't really have the direct settings of the respiratory rates, but we do have the settings of the inspiratory and the expiratory time. We have a number of alarms. So we have the disconnection alarm, we have the FiO2 alarm, we have the battery alarm, and we basically have the possibility by activating this warming button or warming function, we can deliver humidified air. So here we have the compartment for the water. It's here we need to put in the distilled water, and in that case we are able to deliver humidified and warmed air. So we're basically ventilating our patients with humidified and warmed air. An interesting part about this ventilator is that there is no direct setting of the FiO2. You would set the FiO2 by using the table for the air oxygen mix. So for example, you will see here, for example, if you want to reach a 30% FiO2, and we are targeting usually 6 to 8 liters per minute. In our case, my setting would be 1 liter of oxygen, and let me demonstrate this to you. In my case, the setting would be 1 liter of oxygen and 7 liters of air. And by having these settings, we would end up in a 30% FiO2. So what we can see now, we have the possibility to adjust the setting. And if, for example, we are targeting 8 liters per minute, we would then target 1 liter of oxygen, and we can see here the little indicator mentioned 1 liter. And then we can set our air to about 7 liters per minute. And in this case, we would be delivering about 8 liters per minute with the FiO2 setting of 30. So we also have the possibility, of course, to set our inspiratory pressure and peak. So in order to set up the inspiratory pressure, we need to press on this red button. We get to the this alarming level, and then we can increase, and you can pay attention to the pressure gauge here. I'm turning the bar, and we see that we will be delivering. Okay, 30, of course, we don't want, so we would be setting to about 15 millibar. And the same we can adjust to the PEEP setting, or we can go from 0 to the 10 millibar. So depending, of course, on the patient condition, we would target roughly at 5 millibar of the PEEP settings and about 15 to 20 millibar of the inspiratory pressure. So as I mentioned, we can also activate the measurement of the FiO2. Currently, our oxygen sensor is not activated. That's why we cannot get the measurement. And then in order to change the settings, we now also change the respiratory rate. So of course, I would probably target, we have the maximum respiratory rate of 120 breaths per minute. And I can then reduce or increase. So for example, this would be too long. So usually I would set this to 0.3, and I would set this to. So we would target roughly, depending of course on the patient size, on the patient's gestational age, we would target anything between 40 and 60 breaths per minute. So, and now we can measure the current respiratory rates, and the respiratory rate setting goes between 1 and 120 breaths per minute. Also, you would have the indication that there is a pressure in the central supply, and if we have the cylinders connected, we would have also the information about the pressure in the cylinder. Also, if you require, we can use the external gas outlets for delivering also the delivering the non-invasive treatment to the patient. So you see here we can set up the flow, and we can select anything between 250 milliliters to 15 to 25 liters per minute. So this can be used as an auxiliary flow meter. So this is when it comes to the ventilator. I mean, the setup is quite easy. And if we now look at the setup of the incubator, we see that this is the ventilator side, we have the breathing circuit. So the breathing circuits, we can activate also the warming, and the breathing circuit has an external wire that warms up the breathing circuit to deliver warm air to the patient. So we have the humidifier and we have the heated circuit. So that's we are enabling to delivery of warm humidified air to protect the airways and to protect the lungs of the baby. And also by having the humidified circuit, we can potentially reduce the condensation. So you can activate and deactivate by pressing the button here. So when it comes to the incubator, the incubator operation is relatively simple. So we have the control panel here, and let me show you this control panel. So if we look at the control panel, we have the on and off button here. So what we can do, we can press on the on, and then the operation of the device is quite simple. So we have the indication of the battery. Sorry. So we have the indicator of the battery. We have the indicator of the heated elements. We have the temperature setting. So this is the setting for the baby temperature, and there is a possibility to set because we have the integrated temperature sensor, and we can also operate the device in the air mode. So by pressing the arrows up and down, we can now increase the temperature inside the incubator. So basically, we can activate the set temperature, and I can then increase the desired temperature of the incubator to ensure that the baby is positioned in the right thermoneutral environment. So depending on the gestational age of the baby, we would target the temperatures anything between 35 to probably 37 degrees. And we also have to remember that we have passive humidification. We don't have active humidification in this device. So we also have a number of alarms. So we have the high temperature alarm, the heater temperature alarm, the airflow alarm, the power failure, the sensor, and the low battery alarm. And we also have the possibility to deactivate the alarms in case if we know that we're performing a procedure, or if we know that the alarms might come in. So let's have a look at the inside of the incubator. So I'm going to switch off the ventilator, so there is no disturbance of the sound. And you see, we need to confirm. We need to confirm the switch of the ventilator. So we need to confirm the switch of the ventilator by pressing on the silencer alarm. I press the silencing the alarm button and the sound disappears. So let's have a look on how we operate the incubator. So basically on the TI-500, we have two frontal access ports. So you can actually open them by just pressing of one elbow. And you can easily access to the baby through the iris ports. So the iris ports are here to prevent potential heat loss during access to the baby. So we access through the iris ports. and then we can close the access ports. We also have the access port on the side of the incubator, which is also connected with the, which is also protected with the iris port. In order to position the baby inside the incubator, we can open the side wall. So we open the side wall, and we can now position our baby through the side panel. And during transport, it's also quite important to ensure the correct positioning of the baby. Therefore, we can also talk about the different positioning aids even during the transportation of the babies. We have the reusable temperature sensor, which we usually position around the central area, so the chest area of the baby. And here we can have a closer look on the circuit. So you see that it is a reusable heated circuit, which is connectable directly to the ventilation side. So now we've positioned our baby, we can close the side ports, the side door. We have a special window for the correct positioning of the circuit. This is to ensure that during transportation, the risk of disconnection is eliminated or reduced, because we need to make sure that these circuits are protected. That's why we have this positioning window. Also, if we look at the lower side, this is where we can connect our cylinders. We can connect up to 2 cylinders. And also the big advantage of the Globe Trotter 500 is that it has integrated compressor. That means that even if you don't have access to the central gas supply, you will be still able to ventilate your patient with room temperature, of course, unless you have a cylinder. And if you have the oxygen cylinder, you will then be able to ventilate your patients with these settings. So basically, you don't need to have an air supply, because this is a transport incubator, so it has integrated compressor. There's also a possibility to connect into the power supply, or you can also use it in the ambulance for with the AC/DC converter. We also have an integrated battery, and there is a possibility to have 2 batteries which are easily swappable. So basically, we're offering a solution that can be used for transportation of high-risk preterm infants, and it can be used in the ambulances, it can be used in the fixed rotary wings aircraft, and in the airplanes. And of course, we have the possibility to have the tray on top, so it is positioned on these clips, and here we can use this for transportation of the accessories. We also have the cable to ensure the right positioning, kind of a cable clip, and basically you can transfer the baby in the thermoneutral environment with the stable respiratory support and the possibility to transfer the accessories as well. So with this, that's really all what I wanted to cover today. I mean, as I said, probably in the intra-hospital transport, we don't always use the transport incubator, unless, of course, we need to transfer the baby into another building or into the OR. And I know that in Australia, for example, it is a standard to utilize the transport incubator, even in between the labor and delivery and the NICUs. But of course, the main idea is that these devices are normally used in the ambulances or in the helicopter transfer. So with this, I would like to close the demonstration and I would like to reopen again, our session to the questions and answers. I know that we have already have a few questions. So what I'm going to do, I'm going to open the question box and see if we have received any new questions. Okay, so there is a very interesting question that came in, and I think it's more like a case discussion, so let's connect it a bit closer. Okay, so there is a question. We have a 26 weeks neonate in our NICU, delivered by cesarean at term and discharged well. The baby has been readmitted again after 3 weeks with hypothermia, failure to breastfeed. Some investigations reveal high urea, other are normal. HB is normal, temperature has normalized now, SpO2 is good, 98. The main concern now is persistent bradycardia of 60 to 100 beat per minute, despite infusion of dobutamine and dopamine. If you're unable to do echo and ECG, what other investigations can be done to raise PR of the baby? Thank you. So I think, Linda, that would be a question to you. And it's the baby is now 26 weeks old.
So it was a premature infant. It went home and it came back with a history of pyrexia and a low heart rate, and that has normalized, but the heart rate is still problematic. Sure. So I would suspect that if you don't have a cardio echo that you can do, you would have to, something is causing that heart rate to drop. And if it's not a loss of fluid and it's not fluid overload, then I think what you would need to consider is that there's either a cardiomyopathy or there's an acyanotic cardiac lesion for some reason. It would have to be something like that. You know, one would have to see the baby and see what is there, but that would be, for me, what I would consider to be the working diagnosis.
Excellent, thank you, Linda. And there is another question, kindly demonstrate the auto test of the Transport Incubator. So we don't have per se an auto test of the incubator. So what we have though, we can position the device into the standby, and when we switch off from the main power, you see that we no longer have the highlighted alarm or highlighted that we're connected to the power. So now if we turn on the device goes through the automatic self-test. And you will see here that if the device has an issue, normally it would be a heater element, an airflow, or the power failure. These are the main technical failures that are associated with the functioning of the device. Then you will get the alarm or the message on the alarm window. So let me demonstrate that to you a bit closer. Let me just quickly set this up for you. Okay, so you will see on the window here that we have these messages. And again, if I put into the standby, I turned it on, and basically we have the alarm for the power failure, we have the alarm for the airflow, for the sensor, and for the low battery. So that would be basically the alarms that would indicate that we have the technical issues with the device. And that's the only self-check or the only auto test that the incubator goes through at the start of the operation. And similar to the incubator, we can have a look at the ventilator, and you will see here we have, I'm gonna zoom in a little closer again. So we have similar alarm messages here on the side, on the ventilator. We have the disconnection alarm, we have the battery alarm, we have the flow alarm, and we have the oxygen alarm. So this would also be the type of the alarms that you would get when the ventilator has technical issues. So I hope that clarifies the message. Okay, so another question. Kindly demonstrate how to disconnect the ventilator tubing for cleansing purposes. Okay, so for cleaning, what we can do, we basically disconnect. We can open the side port, so obviously we would not have the baby inside. So we take the tubing out. We take the tubing out of the, and then we would just disconnect it from this side here. It's, yep, like that. Then we would disconnect like that, and we would also need to disconnect the temperature probes. It's a bit inconvenient, but basically we would need to disconnect the temperature probes. So basically you would also disconnect the temperature probes. I just cannot reach to them right now. And that's basically how you would disconnect the circuits for cleaning. So it's quite simple, and then after the cleaning, you can then position them back into the circuits. And the cleaning, of course, is recommended after each patient, since it's a reusable circuit, so you can you can disconnect after each patient use and clean it. These are autoclavable circuits, and yeah, basically that is the easiest way to clean the circuits. And also another question was whether this incubator comes with the integrated suctioning module, and this model does not have the integrated suction, so we would need to use the external suction solution in order to perform the suction. So let me just check if we have any further questions. Okay, so I think we have answered majority of the questions. So if you do get any further questions, then you can of course reach out to myself or to Linda, and we will be sharing the webinar recording, and all of you will receive the slides and the recording of the webinar after the webinar. And if you still have any questions, you can always reach out to us at any point of time. And we are taking 1 month break of the webinars, and the next module 5 on the gastrointestinal tract of the neonates is scheduled for September 9th. So if you haven't registered for this module, please visit Dräger website, Neonatal Nursing Course, and register yourself for the upcoming module. And if there is any additional webinars that is scheduled between now and September, we will notify you through the email and also through social media. We are planning to run an additional webinar on potentially breastfeeding and the importance of breastfeeding, and the details we will share at a later stage. So once again, I would like to thank you all for your attention, and I would like to thank you for being part of our webinar today, and I hope to see you all in the coming webinars. And Linda, thank you very much for your time, for your excellent knowledge, and for your expertise. I think really your knowledge helps a lot of a lot of nurses who attend this course. We appreciate your feedback, and if you would like to learn about certain topics, please fill in the survey after the end of the webinar, and we will integrate further topics in these modules. So thank you again, everyone, and I would like to wish you a great day ahead.